米国代表講演といたしまして、シカゴ大学プレシジョン医療研究センター長教授で、世界のがん医療のトップランナーでいらっしゃるマーク・J・ラテイン様よりご講演いただきます。テーマは、米国が描くがん撲滅戦略2024です。
Well, thank you again. And I was asked to speak on the United States plan for ending cancer as we know it. You briefly saw President Biden talking about the cancer moonshot. And the general theme is to end cancer as we know it. And there's been a great deal of focus on the first part of this effort to reduce the cancer death rate by at least 50% by 2047. And probably the most important approaches to this are prevention and earlier detection. Yes, we're getting better with treatment, but it's much better to prevent cancer or to at least find it early than to try and treat advanced disease. But there's a second critical component that can be implemented very quickly, which is improving the experience of living with and surviving cancer. It's the fear not only of cancer, but of the treatment of cancer that is so terrifying. And not only do we want to reduce suffering from cancer, we want to reduce suffering from cancer treatment, including the financial burden of cancer treatment. So much of the current approach to cancer dates to the belief, the dogma, that more is better, that cancer patients must suffer side effects from treatment or the treatment can't work. And that, of course, is a terrifying concept, that not only when you're diagnosed with cancer, you may be facing the end of your life, but you're facing the end of life as you know it prior to diagnosis. There's no other disease that carries the same fear and connotation. But more is better is just religion. It's not proven. And in fact, more and more, the concept has been disproven. Furthermore, international regulatory guidance in regard to treatment, new drugs, states since 1994, more than 30 years ago, that treatment must be optimized, that there's no reason to give higher doses of drugs than are necessary to treat whatever disease the drug is approved for. Yet when it comes to cancer treatment, regulators around the world, physicians around the world, pharmaceutical companies have all based their strategy around the notion that more is better, ignoring the concept, the possibility that the side effects may not be necessary. So in 2016, we founded the Optimal Cancer Care Alliance, which is a charity in the United States, a nonprofit corporation, because many anti-cancer drugs are approved at excessive doses, resulting in unnecessary side effects and excess costs. And we advocate for clinical trials of lower doses and prescribing of lower doses when supported by evidence. In 2021, the United States Food and Drug Administration, FDA, announced Project Optimus, in which they stated that from now on, going forward, new drugs must be developed in a way that where the dose is optimized, and wrote a paper about it in a major journal, the New England Journal of Medicine, that includes the phrase, when less is more, the reverse of more is better. So finally, the United States FDA and presumably other global regulators are figuring this out. A little too late, but better late than never. Patients are speaking up. This is a recent study published by patients. The patient perspective on dose optimization for anti-cancer treatments, a new era of cancer drug dosing, challenging the more is better dogma. This is a scientific paper written by patient advocates. And in August of 2024, just a few months ago, the FDA published a final guidance document explaining how drugs should be optimized, new drugs, for the treatment of oncologic diseases. And I keep emphasizing new drugs. There's been no attention to already approved drugs. There's no impact of Project Optimus, the FDA's new effort, on already approved drugs whose recommended dosage appears excessive. And this is just a small sample of those drugs that I believe are approved at excessive dosages. Now, one drug that I think is particularly illustrative of the problem is a new drug that's approved for lung cancer, for a subset of lung cancer, patients that have a particular mutation in a gene that drives the cancer. And this new drug, sotorasib, marketed under the name Lumakras by Amgen, targets just this one specific abnormal protein. In theory, it shouldn't affect any other proteins in the entire body. Like many new anti-cancer drugs, it's expensive. In the United States, the cost is $845 per day, $25,339 per month. And when it was first approved, it was approved for patients to take 8 pills a day, all at once, 120 milligrams per tablet, a total of 960 milligrams. FDA made the company study a lower dose, 240 milligrams. And this is data from their study showing what the body does to the drug when 240 milligrams, 2 pills, or 960 milligrams, 8 pills, are administered. This is time versus concentration. I've blacked out in red the dosages. One is 240, one is 960. You can't tell them apart. There is no difference. How can that be? If you give 4 times as much drug and you get the same amount in the body, well, it goes down the toilet. A very expensive toilet would be appropriate for such drugs, and I note that the amount of drug that is flushed down the toilet is worth $19,000 per month, slightly less than the most expensive Japanese toilet I could find. And not only is this wasteful from the standpoint of money, but this drug that is not absorbed irritates the intestines and causes severe diarrhea. Yet the company maintains that the 960 milligram dose is the right dose, and as yet, no global regulator has disagreed with them. The US FDA, in fact, supports them, but as Dr. Harris said, Japan should not emulate the United States. This problem is of significant concern to the United States Senate. In fact, Senator Richard Durbin from the state of Illinois actually sent a letter to the chief executive officer of Amgen asking why they're putting profits above patients. Because the company's problem is, if they were to say, you're right, 240 milligrams is the right dose, not 960 milligrams, they would only sell 2 pills per day instead of 8, a 75% decrease in the revenue for this very expensive drug. So we need global regulators to do what's best for patients. Many patients prefer lower doses if toxicity can be reduced without a known decrease in benefit. Some regulators, such as the US FDA, have been supportive of industry concerns that a lower dose might reduce benefit without requiring substantial evidence for that concern. Now, there's increasing concern in Japan about the cost of drugs. And on September 27th, this article was published in the Kyoto News entitled "Life-Saving Cancer Drug, a Boon to Patients, but Price Prompts Debate." What is this drug? This drug is nivolumab, also known as Opdivo. This was a groundbreaking approach to the treatment of cancer and immunotherapy, first approved about 8 years ago. And in Japan, it was approved in 2017, and it was approved globally at a dose of 240 milligrams every 2 weeks, or 480 milligrams every 4 weeks. That's the current approval for it. But that's not the right dose. That's too high a dose. How do we know that? We know that because of a study done in India. So in India, the notion of spending $20,000 a month for a drug is just incomprehensible. And so in India, they conducted a study using a very low dose of this drug, a very low dose that had actually been studied by Bristol Myers Squibb many years ago and was actually shown to be just as effective as the higher doses. But that low dose was never developed by the company, but it's been studied in India. It's 6%, 1/16 of the standard dose. And it showed that it was a very successful treatment for advanced head and neck cancer and likely would work at that dose for many other diseases. Now, the drug doesn't cost the same amount in India as in Japan or the United States, but even at the current price for the standard dose, $744 per treatment given every 2 weeks, that was unaffordable in India. Less than 3% of patients could afford that drug. But yet when they cut the dose to 6%, it changed affordability in India to greater than 75% of patients, simply by giving a lower dose of a drug, a lower dose which may also reduce side effects. So, in conclusion, many cancer drugs are approved at excessive dosages, leading to unnecessary toxicities and excess costs. Avoiding or reducing toxicity will change cancer as we know it. Global regulators should consider the recommended dosage of drugs as carefully as they consider whether to approve a drug, and studies of lower doses of marketed drugs should be a high priority, ideally funded and organized by government agencies. Thank you for your attention.
マーク・J・ラテイン様、ありがとうございました。